I'm Kwamie, an Emerging Voice 2012 from Ghana, and this presentation is on how and why district managers make decisions in relating to implementing maternal and newborn health policies. This work stems from the fact that, like in many other countries, we are off track to achieve our MDGs 4 and 5. While there has been much emphasis and many resources placed on achieving these goals, our indicators are still poor. The situation is serious enough that in 2008, maternal mortality was declared a national emergency. The main policy document overseeing all sectoral action until 2015 is our MDG Acceleration Framework, which is focused on maternal health. This document identifies as major bottlenecks the organization and management of key maternity services such as skills delivery, emergency obstetric care, and family planning. So to this end, the Ghana Health Service is introducing an intervention of CQI, continuous quality improvements, as one way of strengthening district-level management and leadership. We know from the literature that high-quality management and leadership are linked to the progressive implementation of maternal and newborn interventions. However, we are still lacking evidence on the dynamics of these district-level decision-making. This is important because district managers are the interface between national and regional level policy formulation and facility-based policy implementation. Essentially, district managers have the dual role of interpreting policies and leading and managing frontline staff. This leads us to our study aims, which are twofold. The first is to analyze the district managerial governance in implementing maternal and newborn health policies. Here, we refer to governance as being the who and the how of decision-making. Secondly, we want to understand how CQI in turn influences these dynamics. Now, if we accept the complexity of health systems, then it means in considering our CQI intervention, we want to move past just an understanding of whether or whether not the intervention works. In this way, realist evaluation is a useful methodology because it pushes us to ask different kinds of questions. It pushes us to ask questions to try to understand the mechanism underlying the CQI intervention. So such issues as, for whom does the intervention work? What are the conditions which bring about change? Which contextual factors trigger the mechanism and ultimately lead to the observed outcome? So what did we do? 2 districts, one rural district and one urban metropolitan area, were selected as sites to pilot the CQI intervention. These were done in the Greater Accra region because this is the one region in the country where maternal and newborn indicators have indeed worsened. Prior to the introduction of the CQI intervention, we set about building a case study in the rural district to understand these contextual factors. Our managers were made up of 3 types: members of the district health management team, the district hospital management, and sub-district heads. And to guide our analysis, we developed an analytical framework which centered on power, trust and distrust, and decision space as being integral to the relationships and therefore the types and ways in which decisions were being made across the district and up and down the health system. We found that district managers make 2 kinds of decisions. The first are resource decisions, namely around human and financial resources, and the second is programming decisions, mainly around planning and clinical protocols. Now, while resource decisions occur in a top-down fashion, This means that the decision space for them is a bit narrow. Programming decisions tend to occur in a more bottom-up, top-down hybrid. So managers have the space to make modifications, and therefore they have a bit more space to do this. Interestingly, we found that there were 4 factors which in fact bound the way these decisions were made. First, the organizational structure of the system maintains control of resources at the upper levels. This is despite being a devolved health system. The result is that resource uncertainty at the district level hinders managerial decision-making. Managers maintain trust of the upper levels as a coping mechanism to counteract the negativity of this resource uncertainty. And trust of the upper levels is coupled with respect of the upper levels, which in turn acts as a signifier of the hierarchy, thereby maintaining and creating a decision-making cycle. So what are the implications of this? Well, there are many, but we are suggesting that hierarchy and resource uncertainty act in this case as decision disablers. Trust and respect act as decision enablers. And this is important to consider as our context, particularly because CQI in itself has peculiar features which can be in conflict with one another, where it can be about standards and control, but also about learning and creativity. And the lesson here will be that as we continue to investigate our CQI intervention and its influences, we must keep these contextual factors in account as we try to understand what the possible outcomes will be, whether this intervention can contribute to strengthening management and leadership at the district level, and ultimately, whether this can contribute to improving the organization and management of maternal and newborn services.